I'm very excited to introduce you to our next speaker. Before I do, though, I just want to remind folks that are joining us and have either been with us all day or who may be joining in and out. Lots of information is being put in the webinar chat, so feel free to check there if you have questions. But you're also welcome to ask our team questions in the Q&A feature as well. Be on the lookout, though, for more information to come, again, about links to different things and what have you in the chat, in the Zoom chat. Again, as a reminder, thank you so much for all of you who are submitting questions for our speakers. I'm doing my best to make sure that we get to as many of those as we can, and are also making sure that we have those so that we can come back around to them if time allows or when other opportunities arise. And so certainly want you all to know that we appreciate the engagement and want you to know that we are closely watching all of that information. So, but without further ado, I want to ensure that we have plenty of time to hear from Dr. Josh Smith. As a reminder, his full professional bio will also be in the chat. We like to save time and make sure that most of our effort is applied to the content, and so I'm not going to be reading that out loud to you. Nevertheless, Josh is an expert in the field, and so Dr. Joshua Smith is an incredible human being and very, very passionate about what the work that he is doing and what he's going to be sharing with you. So we're going to be talking about catatonia and autism, what everyone needs to know. That's an important statement there because you may be like, I don't need to know anything about catatonia and autism. And I would argue that yes, you do. So whether you're a professional, whether you're an autistic person, whether you're a caregiver or a parent, this is a very important topic, something that I have had the opportunity to learn more about from people with lived experience, being close to the parent of a young man who has significant catatonia. And so certainly she has been a very important place in my world in helping me to understand catatonia and how important it is for me as a clinician to understand it. And so certainly I want to highlight how important that is. But Josh is going to talk to us about an overview about catatonia with a focus on how it presents in autistic individuals. We're going to be drawing on clinical experience as well as research that he has done in this space and discussing signs and symptoms of catatonia, common misdiagnoses, because I can say that's definitely a common thing, and the importance of early recognition. We're going to talk also a bit about the evidence-based approaches to diagnosis and treatment. And so please join me in welcoming Dr. Joshua Smith. For the next 45 minutes, we're going to hear from him talking about catatonia and autism, what everyone needs to know. So over to you, Joshua. It's great to see you.
Yeah, great to see you too. Thank you so much for the invitation.
Of course.
Um, I always am a little overly ambitious with my time, so I'm glad that we have a timekeeper, but I will go as quickly as I can.
You're fine. Go
So,
for it.
again, catatonia autism, everybody needs to know. And again, I'm Dr. Smith. It's nice to meet everybody. So I have a couple disclosure slides here. I'm going to show you all some videos today, and they're videos of patients that I've taken care of and continue to provide care for. And they are distressing videos. Catatonia is a devastating illness that seems to impact folks who are on the spectrum more often than others. And so, but it's really tough to watch. And so, if you're not in the space today where you feel like that you can watch these videos, I'll give everybody a moment to step away. All these folks are doing much better. I do have videos of them doing well at the end. But again, if today is not the day that you can view those, that's okay. I am the medical director of the MIND Exploration for Neurodevelopmental Disorders Clinic. We do clinical trials with these pharmaceutical companies. None of them are related to catatonia at all. And then I also get support from NIH from these two grants, again, not related to catatonia. So we're going to look at a history of catatonia and its presentation in children and autistic individuals. And I've included kids in this because what we've noticed in our research is that the folks with autism who are presenting with catatonia are younger, and there are really specific pediatric symptoms of catatonia that we're going to review. And so we're going to talk about treatment planning for cases of pediatric and neurodevelopmental catatonia. We're also going to look at medication interventions and also neuromodulation, particularly electroconvulsive therapy, and talk about what electroconvulsive therapy is, what it looks like, and how it can help and really is a life-saving and life-sustaining intervention for these folks. So what is catatonia? So despite the fact that we described catatonia since 1874 by Dr. Carl Cobham, we really have not done enough research on catatonia, particularly as it pertains to autism. And part of this is that we really didn't describe catatonia occurring in autism until the seminal text in 2000 by Doctors Wing and Shaw. But catatonia is a syndrome. That means that it's usually caused by something else. The way I describe it to my families in clinic is it's similar to fever, right? So you have fever from the flu, you have fever from X, Y, or Z. You have to treat the fever and then also treat the underlying condition when you're able to. It presents with mood changes, movement changes, and specific examination findings. And so this is sort of the classic picture of catatonia, where someone's posturing, they're mute, they don't eat, they sort of waste away. But hyperactive symptoms appear to be more common in folks with autism. And we actually only described catatonia occurring outside of schizophrenia when we switched from DSM-4 to DSM-5. So up until that point, it was thought to be a comorbidity of schizophrenia only. But now we know that it impacts people across the spectrum of mental and physical health, and I'll show you what that looks like as well. And we're also doing a much better job of recognizing catatonia in children. And if you were interested in a history of catatonia, this book by the illustrious Dr. Fink, who we unfortunately just lost recently, I think he was 102, but he did a fantastic job writing a history of catatonia if you want to read more. Okay, so what causes catatonia? So again, catatonia is caused by an underlying medical, psychiatric, or neurodevelopmental condition. We conducted this very large look at inpatients, so folks that were hospitalized for catatonia and what was the underlying etiology. And so we identified 62,000 adults, and most often these adults had mood disorders, so bipolar disorder, depression, so on and so forth, and became catatonic secondary to that. For children, we identified over 3,000 kiddos. It was more often to be caused by a psychotic disorder, a neurodevelopmental disorder like autism, encephalitis or autoimmune conditions, and then there were a myriad of different other causative conditions, including delirium, electrolyte disturbance, drugs, epilepsy, depression, urinary tract infections, so on and so forth. So if it's treatable, it's critical to identify and treat the underlying condition, but it's not always a treatable condition. So particularly for folks who are autistic or who have underlying neurodevelopmental sort of like Down syndrome, you can't really intervene upon that. And so it's really important to be able to treat the catatonia as quickly and as rapidly as you can, even if the underlying potential cause of the catatonia is not something that can be adjusted. So when you look at, I need to actually hold on. Let me make sure I can share my audio. Give me one second. We'll see if I can share it when we get there. So when you look at catatonia and how it presents, this is actually a study that we did of emergency departments where there's a bimodal age distribution. So you can see most people presenting with catatonia were either on the younger side or they were on the older side. And again, we found that adult patients with catatonia were more likely to be female and white and have a comorbid mood disorder. And children with catatonia were more likely to be male and non-white and have comorbid neurodevelopmental disorders. And interestingly, just to make sure that we all appreciate how severe this condition can be, which Dr. Soul sort of alluded to, is that when people present to the emergency department, they're admitted at an incredibly high rate at about 82.6% of the time. So when I say admitted, it means they're going into the inpatient hospital, receiving inpatient medical care. And this is actually very similar to things like congestive heart failure, status epilepticus, and pulmonary hypertension, much higher than our psychiatric conditions such as bipolar disorder or schizophrenia, which are our two highest conditions most often associated with admissions. And this is just a quick look at this. It's really interesting how many of the catatonia presentations presented in the US South, which is where I am. I'm at Vanderbilt. I was particularly sort of stunned by this much higher number here. And then it looks like the rate of catatonia or the prevalence of catatonia is increasing year over year, which I can actually show you in our data is what we've seen too. And it's a question of, are we getting better at detection? We certainly are. Are there underlying causative agents within society kind of broadly that may be contributing to increased rates of catatonia? It's hard to know, but certainly the rates are definitely rising. And then if you look at where these cases present, they most often present to metropolitan teaching hospitals, which again is really fascinating, right? Catatonia does not self-select for presenting to these hospitals, but nevertheless, they're much more often identified and treated in metropolitan teaching hospitals. So I showed you the little picture before of the kind of classic picture of catatonia. But this is catatonia alternates between hypoactive and hyperactive. So for hypoactive symptoms, there's significant psychomotor slowing, posturing, fixed gaze. This is the classic version of catatonia. And then there's hyperactive catatonia, which is extreme agitation. There's a higher risk for a misdiagnosis. And this is more common in pediatrics and neurodivergent populations. And these can present between the two. And I have a video where I'll show you of a child who's alternating between hypoactive symptoms and hyperactive symptoms as well. But certainly, folks are more likely to present with hyperactive symptoms if they have a comorbid neurodevelopmental disorder or they're an autistic individual, so on and so forth. So these are the scales that we use to assess catatonia. Bush-Francis is the most common, it's the most widely used scale. It's the gold standard, but it doesn't have great mood data or pediatric data or data that impacts folks with neurodevelopmental differences. And then the pediatric catatonia rating scale was developed from the Bush-Francis. It includes a greater focus on pediatric specific symptoms. Those include urinary incontinence, acrocyanosis, which is cold extremities, and then automatic compulsive movements. And then my favorite scale is the Connor Catatonia rating scale. It's not validated, but it includes a severity measure and a standardized physical exam. It's designed for catatonia and neurodevelopmental disorders. It's more precise, but it does miss pediatric specific symptoms. It is the only one that measures recurrent self-injury as a mannerism or a stereotypy. And one particular symptom of catatonia that presents in autism is this recurrent self-injury. So self-injury that's occurring not in the context of communicating with someone, not in the context of distress, but just automatic and really severe. So we can see patients who are, poking fingers in their eyes or are, rubbing their skin so hard that they're losing skin integrity. And the Connor is the only one that actually assesses for that self-injury, which is a really key component of the presentation. And I'll show you what that looks like here in a moment. So a quick plug for two papers. This is a fantastic paper about catatonia in neurodevelopmental disorders, essentially saying that there's a catatonic deterioration from baseline because when you observe catatonia in neurodevelopmental disorders, folks oftentimes lose the ability to accomplish their activities of daily living, things that they were previously able to accomplish, they're no longer able to accomplish. And that is a really key component of this disease in folks with neurodevelopmental differences, but that's not captured in any of the assessment scales that we previously reviewed. So they discuss this in this paper. And then this recent publication that I was fortunate to be part of is in the Child and Adolescent Psychiatry Journal. It is the largest review. It's over 200 references talking about catatonia and autism and neurodevelopmental disorders. So if you want to read more, definitely a plug for this paper. It is absolutely comprehensive. So why should you, the audience or anyone, really care about catatonia in children and neurodiverse individuals? So catatonia is associated with a 60-fold higher risk of death in children relative to the general pediatric population. This is because of malignant catatonia, which is catatonia that can occur in vital sign abnormalities, reduced oral intake, deconditioning, choking, so on and so forth. Pediatric catatonia also presents with high support needs. These patients frequently relapse, and we're working on collecting data and showing what that looks like. They often present to inpatient levels of care and require high-level outpatient services. And we talked about this again, often likely to present with recurrent self-injury, negativism, or physical aggression. And we could treat catatonia. So that's the thing, right? Is it's a really devastating illness that's hard to detect and hard to diagnose. But if we do it, we can treat it with electroconvulsive therapy, which is unfortunately a highly stigmatized and restricted treatment, which we'll talk more about at the end here. And if left untreated, catatonia can become malignant. And the symptoms of pediatric catatonia and catatonia occurring in folks with neurodevelopmental differences can be misattributed to things like oppositionality, like folks just don't want to participate or do what you're asking them to do, agitation or aggression. And then again, symptoms are unique to children and the rates are rising. So this is our look at our children's hospital for pediatric catatonia. And you can see the rate of, so this on the left here is the rate of pediatric catatonia diagnoses in the entire hospital. And you can see it's holding pretty steady here until 2021. And there's a huge jump, a nearly tenfold increase in the number of catatonia diagnoses. And that number has continued to rise. And then our friends at Boston Children's also reported a very similar finding where they had a 3 times elevated prevalence of catatonia. Now we're going to take a break from data for a little bit, and I'm going to show you some videos of some patients. Again, all their families were very eager to share these videos with you all. I'm hoping the audio will work. If it doesn't, I might need a minute to navigate that. But this is TR, so he is 9 now. He was typically developing until about the age of 5, and then he had a sudden catatonic deterioration with significant self-injury and aggression. He lost bladder and bowel function. He was also diagnosed with autism around this time as well. It's hard to say if he really met criteria for autism or if he was diagnosed in lieu of the catatonia diagnosis that was missed for a while. He also had an extensive medical workup that returned within normal limits. He had some genetic findings that were of unclear significance, and we tried him on every single medicine we could think of, and none of them were effective. And he also received intravenous immunoglobulin because we thought he may have encephalitis, and that's one of the treatments for that. So I'm going to show this video of him. This was before he was ill. And Kristen, can you tell me if you can hear this?
Yep, I sure can. I mean, I can't hear it yet, but I will tell you. I cannot hear it.
Okay, let me work on that for a quick second.
Yeah, you bet.
Sorry, everyone.
So, Josh, I don't know for sure about the issue you're navigating, but typically, if you stop sharing and then select like when you reshare, select share audio, and then that usually will fix it.
All right, let me see. This is not giving me the option to do that.
Hmm. Okay.
I wonder if it's because of my headphones. Let me try that real quickly.
Okay.
Here we go. It's not letting me click it. I apologize.
It's okay.
Okay, well, I'll continue.
Okay.
We can look at some of the videos and see. But anyway, he tells a little joke. He's doing quite well. Fortunately, he has a significant regression. And again, if you need to step away and not see a very challenging case of severe symptoms, that's okay. So you can see here, he's having very severe recurrent self-injury. He's trying to bite himself in the arms. He has a helmet in place to keep his head safe. And he's also, at this time, has completely stopped sleeping and is having excitability. And this is another patient, FH. You won't be able to hear the video here, unfortunately, but he was engaging in new onset self-injury where he's hitting himself in certain places of his body. And he has a really loud noise that he started making around age 10 that he just could not stop making to the degree that he started damaging his vocal cords. And this is my friend GL. So this is GL. She had a diagnosis of autism before she was diagnosed with catatonia, and this is her before she became sick. She became catatonic, and the family was seeking ECT for treatment because she had failed multiple medicines. But they live in Texas, and we'll talk about this a little bit. But in Texas and in California, children under 16 categorically cannot access ECT at all. She was hospitalized for months. They weren't able to do ECT for her. Her dad found out that we would do ECT here at Vanderbilt, and he asked for discharge, got in his car, and just drove straight to Tennessee asking for care. The family unfortunately had to quit their job seeking care, and they're also living in a trailer outside of town and are able to work at this time. but this is how she presented in the hospital. You can see this is more classic of this kind of posturing presentation, but then she'd fluctuate between this and then also having this hyperactivity. So this is called motor perseveration, where she's repeatedly engaging in the same behavior over and over again. And then she has this orofacial dyskinesia, so this sort of repeated grimacing of her mouth that you can see there. And that is more consistent with pediatric catatonia than it is adult catatonia. She also had a lot of aggression and self-injury, but as we've seen other videos of that, I did not think it was necessary for this. And then this is another friend. This is LS. He has Phelan-McDermott syndrome and profound autism. You're not going to be able to hear it, but he's screaming at the ground repeatedly. And as he became more ill, his screaming, he eventually advanced to being completely mute. And you can see that he's doing what I would call a mannerism, which is where he picks up these chairs and tosses them oddly. And you'll just do this all hours of the day. And then he pauses and his posturing is right there. And it is very subtle, but if you're looking for it, you can absolutely see it. He'll do it again here in a minute. And again, posturing right there. And you can't hear it. I'm sorry for that again, but his sister's trying to calm him down, but is unable to get through to him. And this is our last friend, BE. He's from East Tennessee. In a similar presentation, he lost a lot of weight because he stopped eating due to catatonia and a lot of self-injury. This is him in the Children's Hospital in East Tennessee. So let's talk a little bit about autism, intellectual disability, and disparity. So autism and intellectual disability, about 30 to 50% of autistic individuals have a comorbid intellectual disability. And despite that, they've only been included in about 5 to 6% of clinical research. And that inclusion is actually getting worse over time, not better. And they have a significantly elevated risk of externalizing behaviors, aggression, self-injury, so on and so forth. And so when a physician sees a patient with autism, either with or without intellectual disability, I like for them to consider catatonia on their differential, because this paper by Vicchioso Serrano showed that about 10% to 20% of autistic individuals have experienced some degree of catatonic symptomatology. And what we found in our studies is that folks with autism and comorbid intellectual disability appear to be at an even higher risk than folks with autism without intellectual disability. And so my encouragement to my colleagues is always to consider catatonia on your differential when someone's presenting with new onset self-aggression or violence or negativism where they're not able to listen, reduced oral intake, and so on. So these are the consensus guidelines from 2023 about how to treat catatonia. And we treat catatonia, the first option is Ativan, so lorazepam, and it works very often. But unfortunately, in all these cases, standard doses of benzos, including lorazepam, were not successful. And this is what we have from 2017 from Dr. Beach and colleagues here. So this is our stepwise algorithm for taking care of folks with catatonia in adulthood. So you start with Ativan, and then you go to ECT, which again, we'll spend more time on here, and then a glutamate antagonist, an anti-epileptic drug like Depakote or Tegretol, and then potentially an atypical antipsychotic, which is really tricky because some of the atypical antipsychotics can actually worsen catatonia. But when you're a pediatric psychiatrist and ECT is really difficult to access, unfortunately, the list goes more like this. So I'm going to share with you some data that we have from our clinic. This is the first 3 years that our clinic was open. So we treated 45 autistic patients with comorbid catatonia from July to May. The mean age was about 15 and a half, mostly male, but a significant proportion of female. And then about half and half were diagnosed in the inpatient and outpatient setting. 91% of our patients also met criteria for intellectual disability, which I was shocked by when we went back and looked at it, but the numbers speak for themselves. And then almost half of them also had a history of having seizures, and then 7 of them had a history of epilepsy. Genetic syndromes are relatively common, as was ADHD. But again, if someone's having hyperactive symptoms of catatonia, it's hard to really separate out if that's ADHD or not. The most common symptoms were impulsivity and staring, followed by stereotypies. 20% of our patients had self-injury from a stereotypy. 12% of our patients had self-injury from a mannerism. And that motor perseveration that you saw, the repeated motor movements, that was present in about 60% of our patients. An ambitendency, which we haven't talked about yet, but it's a really interesting symptom of catatonia where people are unable to completely do a physical movement, was present in about 42% of our patients. And then vergibration, which again, I apologize so you can't hear the videos. Um, this patient has the screaming vocalizations that again are so intense that it can cause vocal cord damage. And that's the vergibration that, if untreated, can eventually progress all the way to complete mutism. So 38 of the 45 of our patients had previously been on a psychiatric medicine, and they had failed a lot of them. So the average number of failed psychiatric medications was 5, and we had 2 patients who had failed 16 different psychiatric medicines. So we started treating folks with benzos first because that's what you do. And the mean dose of Ativan that we needed to treat these patients so was astronomically higher than I was expecting. So it was 17.4 milligrams, which is a really, really high dose of Ativan. And so there's this old adage of catatonia care, it's been around forever, that you treat catatonia until sedation. Most of them required more than one class of medications for treatment. And there were no severe sedation or respiratory issues despite this really high dose of Ativan. So one big challenge is that when patients were stable, we wanted to take them off of benzos. We wanted to take them off the Ativan. So 14 of them, we attempted a benzo to taper. 9 of them were discontinued because their catatonic symptoms returned. And so we were only able to successfully taper 5 of the 45 patients off of the benzodiazepines. And this is another figure just showing you how many different medicines these folks needed for stabilization. So if someone needed more than one medicine, they're in this 2 category or 3, 4. So you can see a significant majority of our patients needed either 2 or 3 different kind of psychiatric medications to achieve stabilization. And ECT was recommended for 22 of the 45 of our patients. It was deferred for parental preferences, transportation challenges, insurance issues, and 16 of the 45 went on to get ECT. I have more up-to-date data on that. I'll show you here momentarily. So when we assessed clinical improvement on the Bush-Francis and the Canner, we had statistically significant improvement in the Bush-Francis and the Canner exam. Probably not the Canner severity scale because there's a lot of symptom crossover that we saw there, but there was still some trending of improvement. And this is the global impression scale. Just want to introduce to you really quickly. So this is a measurement-based system where physicians can identify if there's improvement. So 4 is no change, 3 is minimally improved, 2 is much improved, and 1 is considered remission, so very much improved. And in the opposite direction, 5 is minimally worse, 6 is much worse, and 7 is very much worse. And based on our evaluation of our patients, most everybody got better. Everybody got better. 6.7% had only minor improvement. Only 9% had full remission, and then 80% had some degree of improvement over 3 years. Unfortunately, we had 3 patients pass away in the study too. All of them had profound autism. The deaths were unrelated to treatment. It was due to choking and then recurrent pneumonia and then likely an underlying cardiac issue. If you want to read more about this, again, just identifying even further disparities for folks with autism and intellectual disability, there's significantly elevated rates of mortality for folks with autism and comorbid intellectual disability and cerebral palsy independent of catatonia. And so catatonia on top of that certainly increases the risk of morbidity and mortality. So everyone improved our key findings, but few patients returned all the way to baseline, so less than 10%. Use of high-dose benzos and multiple medications was common. There were actually no severe adverse events related to treatment that were reported, but all-cause mortality remains very high. And tapering of the benzos was really difficult, and support needs were also very high. So I told you earlier that these folks present often to the hospital, and we wanted to look at what if we compared catatonic patients who are neurodivergent versus catatonic patients who are neurotypical in our pediatric populations, would we see some sort of signal, or is there something that we could identify between those two populations? So we did a retrospective analysis between Vanderbilt and Mass General. We identified 165 pediatric catatonia kiddos. 50% of them had a comorbid neurodevelopmental disorder. The median dose of benzos was 6 milligrams, was much lower in the inpatient setting actually than we expected. These kids were hospitalized for a median of 5 days. Hospitalization exceeded 30 days in 10%. 40% of patients went on to be psychiatrically hospitalized, and 91% of them were discharged home after a medical or psychiatric hospitalization. Interestingly, neurotypical children with catatonia were hospitalized for longer than our neurodivergent patients with catatonia. And is this good news? Well, if we really looked at it too, we applied that CGAI that we talked about, and we found that the probability of improving by either a 2 or a 1 was 88.3%, and 98.5% of our patients improved at least a little bit. And then the probability of complete remission was 23. But when we look at these numbers, the only thing that we could find for these patients that were associated with was associated with the lower odds of clinical improvement was a comorbid neurodevelopmental disorder. So our kiddos with who are neurodivergent were with catatonia were discharged sooner than neurotypical children and had less overall clinical improvement. This is just a fun little graph looking at the Bush-Francis scores, showing you that everybody improved. So neurodivergent children were hospitalized for shorter periods of time but had less improvement. Why is that? There's a couple of hypotheses around this. Certainly, there's a high degree of symptom overlap. So a lot of catatonic features in autism can look like autism, but just a more severe iteration. So again, the stereotypies worsening to the degree of self-injury is a good example. Reduced eye contact is a baseline feature of autism, but in catatonia, it can become fixed staring. So again, you can get some diagnostic kind of crowding. So there's certainly that may be contributing. There's also less tolerance in the hospital for children with neurodevelopmental disorders. We've known this for a long time. And there's also a lack of inpatient options. So there's really only one neurodevelopmental inpatient unit that I'm aware of in the country who can manage catatonia inpatient. And so again, it likely leads to earlier discharges and more follow-up in our clinic. So this is certainly an area of future research we need to look at to address disparity. So what about ECT? So ECT unfortunately has a really bad rap because it was used inappropriately in the early 1900s. The ECT has been around since 1940. It is the most effective thing we have in psychiatry transdiagnostically. And now in the modern age, we put people under generalized anesthesia, we sedate their muscles, or we paralyze their muscles. And after they're asleep and their muscles are paralyzed, we use ECT to induce a medically controlled seizure. It is incredibly effective. It is actually a very safe intervention. I've treated folks as young as 7 all the way to 97, despite the stigma that's associated with it. And there's a concern for short-term and long-term memory side effects, which is certainly a known side effect of ECT. But it looks like longitudinally, those side effects are not as severe as once was concerning. And particularly because we've adjusted the way we do ECT. So if you'll forgive me for a moment, a little physics, this is a sine wave of an electrical pulse for ECT. And around 1970, this became block waves like this. So you can see the pulse width, so the duration under the little curve here, reduced significantly. And we showed that folks still had the same amount of improvements, but much fewer cognitive side effects. And so that's what ECT looks like today. So it's FDA approved for kids 13 and up, and then all the way throughout the entire life cycle for catatonia. It's also FDA approved for depression with response rates of 60 to 80%. And this is compared to 40% for pharmacologic interventions. It's effective for bipolar disorder, both the manic and depressive phases. And it's actually the only treatment that we have in psychiatry where it's more effective if the patient is experiencing psychosis. Most of the time, medications are less effective if psychosis is present. It can also be used to treat refractory Parkinson's disease and status epilepticus, which are seizures that do not improve. It may seem counterintuitive, but the seizure that's actually induced by the ECT is actually very different than a spontaneous seizure. And so if you do ECT, you can actually break status epilepticus. So if somebody is seizing and they're unable to stop seizing, you can use ECT to actually stop that. There's a really interesting protocol at the University of Maryland that they use. So it's very safe and often life sustaining or life saving intervention for adults and children, but use and availability is unfortunately limited, particularly for kiddos. So again, California and Texas, 16 and under, it's complete non-starter. And then there's also provider availability and willingness to treat patients. So Kentucky, just north of us, has less restrictive laws than we do in Tennessee, but they just don't have any providers. And so there's just not somebody to treat them there. And there's also been survey studies that show that pediatric psychiatrists are generally uncomfortable with ECT. In the state of Tennessee, if you want to get ECT and you're under 18, if you're 14 to 17, you have to have two consultations with two different psychiatrists. So one is an ECT doc, and the other is a child and adolescent psychiatrist. And you have to be, you or your parent or your surrogate have to be consenting for ECT for that to happen. If you're under 14, you still have to have those consultations. You also have a meeting with five or more providers at the institution, a multidisciplinary team meeting, and then you go to court, and then the judge decides if ECT is okay for you to receive. And that's only, again, if the parents or the surrogate are consenting for treatment. And so the threshold, the bar for approval for ECT is quite high to be able to obtain. So I just wanted to introduce some policy statements about ECT. So this is the American Academy of Child and Adolescent Psychiatry. I won't read this whole thing to you, but they've recently had a statement that's come out that said that they recommend that children and adolescents have access to ECT when indicated. And we also strongly suppose any efforts, legal, legislative, or otherwise, to block access to ECT. And they support continued research for ECT in children and adolescents with psychiatric disorders. And then this is a joint statement by the World Psychiatric Association, the American Psychiatric Association, and the European Psychiatric Association around WHO guidance, so the World Health Organization guidance around ECT. This is something I could spend an entire separate talk discussing, but essentially the conclusions from this joint statement from these organizations was that if someone is critically ill and they have catatonia, they should be able to access ECT. If you want to read more, I would encourage you to do so. But what I'll show you is that there's a significant degree of morbidity that's associated with these restrictive legislations. So this is a child who doesn't have autism, but I think is an important case. So we were unable to start ECT for this child. She was in the hospital. She had not eaten for a week. She was on an NG tube feed and IV hydration, and we needed to do ECT for her. We had tried treating her with medicines. It was completely ineffective. And we petitioned the court for access to ECT. And despite the fact that we have a really good relationship with the court, you have to get it scheduled and you have to get the lawyers in there and everything. And so it took 16 days for us to access ECT for her. We managed to start treatment for her, and you can see her symptoms significantly reduced. And she was able to eat on day 27. So again, a significant degree of delay in access. And just a quick history of pediatrics and ECT and autism and ECT. So in 1943 is actually the first documented use of ECT for children. These children had schizophrenia diagnoses at the time, but they probably would have autism diagnoses today, because back then these kids didn't have psychotic symptoms. They had primarily more negative symptoms of schizophrenia that we probably would have diagnosed with autism rather than schizophrenia. And in 1982, ECT is used to treat recurrent self-injury in a 25-year-old man with intellectual disability. In 1999, Dr. Fink, who I referenced earlier, treated a gentleman with a very similar presentation, autism, intellectual disability, and recurrent self-injury. And the individual improved so much that he was actually able to be discharged from the institutional setting. And then in 2000, Wing and Shaw introduced a population-based study of catatonia and autism. And since this time, there's been tons of case reports and series and retrospective analyses that investigated the use of ECT in this population. And for many years, our ECT docs have told us that our autistic patients with catatonia need more treatments for a longer period of time than our non-autistic individuals with catatonia. And we conducted an observational study to see if that was the case. So this is hot off the presses. This is not published. We're working on it. We conducted an observational cohort study where we compared autistic and non-autistic patients with catatonia who got ECT at Vanderbilt from May of 22 to December of 25. Informed consent for ECT was obtained consistent with Tennessee state laws, which we've already discussed. And then informed consent for research participation was waived because this is just part of routine clinical care for data that we are collecting. So we included anybody who received an acute series of ECT. So this is an important distinction. An acute series of ECT, when you first start getting ECT, you come either twice or three times a week, you improve, and then we slowly space your treatments out. So we go weekly, every other week, monthly, and so on. When you space out those treatments, those are called maintenance treatments. And the ECT providers all across the country and the world have said our autistic patients with catatonia have a really hard time transitioning from acute to maintenance treatments. When we space them out, their symptoms come back, we have to bump them back up. But we didn't have any data that actually showed this. So that's part of the reason we conducted this, to see if that was the case. So we identified 33 autistic patients with catatonia. Consistent with our previous research, the folks were much younger who were autistic with catatonia. They're 18. The majority were treated as outpatients, and the majority had intellectual disability. Again, this is consistent with the hospital study I showed you, and then our longitudinal clinic study. And there are 47 non-autistic patients with catatonia. The mean age was 37, and most were treated as inpatients. So there are almost 2,000 total ECT procedures that happened over the study period, and the majority of them took place as outpatients and then a significant minority took place as inpatients. So this is where I would usually do a show of hands if we were in person, but I'll just have you think about it. So by a show of hands, how many autistic individuals with catatonia actually required more treatments than neurotypical individuals? Do you think that they did? And if they did, how many? How many more ECT treatments do you think they needed? And when we analyzed the data, even I was surprised. I knew that our autism patients with catatonia needed more treatments over a longer period of time, but I was very surprised by the numbers. So the mean number of total ECT procedures needed in the autism and catatonia group was 34. The median was 31. In the non-autism group, it was 18 and 16. So almost double the number of ECT procedures were needed for the autism and catatonia group. The median duration of treatment, so how long they were receiving ECT, was almost a year for the autism and catatonia group, and then non-autism was 106 days. And if you look at this, this is just some fancy math showing you that this is statistically significant differences between those two numbers, which honestly we didn't need, but you still need to do it for papers like this. So side effects, so the total number of ECT procedures across both groups is almost 2,000. Serious adverse events were really rare. So we had prolonged seizures that needed propofol to treat them. So a seizure that lasted longer than 3 minutes after ECT in 60 cases, so 3.1%. And we had one patient who had 2 episodes of aspiration pneumonia, and he was treated in the medical hospital, and ECT was able to be resumed. And then we had one patient who had 1 episode, and ECT was resumed for them as well. This is really tricky. So the number of patients who were actually able to tell us if they had subjective adverse events, so things like memory difficulties or muscle pain, muscle soreness, so on and so forth, is very low because the number of patients, so 45 of our patients weren't able to tell us due to catatonia. So one of the core features of catatonia is mutism. And so it's really hard to assess for subjective side effects if someone's mute. And then many of our patients had autism with intellectual disability and weren't able to report those side effects as well. So you can see here, we had really significant clinical improvements. So that CGI-I score I showed you earlier, 91% of our patients had a score of a 1 or a 2. And then in the non-autism group, it was 85%. And then 63.6% had a 50% reduction in their catatonic symptoms as compared to 57. And I know I'm running out of time, so I'm going to go quickly. This is the CGI-S. So this shows you how severe someone is. If someone is a 7, they're likely in the hospital. If they're a 6, they may require assistance from others due to their symptoms. And if they're a 5, they have intrusive symptoms that impair their functioning. So any level you go up, even 1 step, is a significant improvement. So you can see here we had statistically significant improvements in the Bush-Francis here, baseline and last treatment, and the CGI-S, baseline and last treatment. And again, 7 is in the hospital, 6 is requiring assistance from others, and 5 is impaired functioning. So the reduction from a 6.3 or so to the 5s is really significant. And this is just another way of visualizing the clinical improvement from the CGI-S and the Bush-Francis. This is kind of an interesting finding. I think this is mostly from us trying to space these patients out. So they've gotten lots of treatments. We're trying to get them less frequent treatments, and then catatonic symptoms end up returning. So our key takeaways is this is the first data set to look at maintenance ECT and catatonia, either for autistic or non-autistic patients. It's also the very first study to compare autistic and non-autistic patients with catatonia for treatment. And if you want to read more about maintenance ECT across diagnoses, this study out of Denmark is tremendously helpful. They showed reduced risk of hospitalization for anyone getting ECT for any indication, as well as reduced morbidity and mortality. So this is really important. Similar to our pharmacologic approaches for catatonia and autism, ECT should probably be considered a treatment rather than a cure for catatonia. So historically, folks have said you get 6 to 7 treatments for ECT, boom, your catatonia is gone. but that actually does not seem to be the case, particularly for our folks with catatonia and autism. We really need to do more research in this area and learn more about it, but this, I think, is a really good first step. And again, transitioning to maintenance treatments is really similar to benzos because we had a hard time tapering the medicine to treat catatonia. We also have a hard time tapering the ECT to treat catatonia. And then I'm going to kind of skip forward a little bit because I wanted to show you my friends. So this is KR. He was admitted to Kennedy Krieger for ECT because I couldn't give him ECT here at the time. Since then, I'd be able to. We didn't have pediatric anesthesia available, but he was transferred there. And you can see these are his severe behaviors. And then he started ECT 2 times a week, twice a week, once a week. And you can see nearly complete extinguishing of his symptoms. Unfortunately, you can't hear this video, but I'll tell you, this is him in his house asking his mom to watch Toy Story. So again, he's certainly not back to baseline, but a tremendous improvement from where he was. This is our friend AFH with significant improvements as well. I saw him yesterday. He's doing fantastic. This is GL. Again, near complete resolution of catatonic symptoms. This is our friend LS. This is he and I on his birthday. He's adorable. And this is BE, who received treatment. And again, you can see significant improvements from where he was. And these are some feedback we've gotten from our families. So ECT is our lifeline. We're so thankful for it. ECT is the first time my son gave me a hug. He wrapped his arms around me. He's so much better now. His severity went from a 10 to a 5. My son slept well the first night after ECT. My daughter is doing so well, learning to take care of herself again. Aggression and self-harm are much reduced. The treatment's made a huge improvement. My son went to school today for the first time with some irritability, but improved from baseline. We're finally seeing results. So you can see from all of our families, these subjective reports are really powerful as well. In the interest of time, I'm going to skip this. We designed a catatonia screening tool and a catatonia pathway at our children's hospital. If you're interested in learning more, just let me know and I'll pass those articles to you. Our big takeaway points are that catatonia is an identifiable and treatable cause of regression and aggression across the life cycle in neurodiverse and neurotypical people. Children and neurodiverse individuals more often present with hyperactive or aggressive symptoms in catatonia. Children present with unique symptoms of catatonia. This increases the risk for misdiagnosis. ECT and high-dose benzos are the gold standard of treatment. ECT is a life-saving intervention for adults and children, but access is limited due to stigma and limited education. We've been safely utilizing ECT since 1940 with recent advancements, not recent, since 1970, where we started using anesthesia for ECT. And then it looks like more ECT treatments are needed over a longer period of time for the autism and catatonia patients relative to non-autism. And this is really important because this is something that we can actually take back to hospital leadership and say, we're doing a really good job taking care of these very sick folks, but they need more treatments. How can we adjust our systems to be more inclusive of these patients? Can we open up more time slots for ECT to be able to provide care for these folks? So it's both I think, a super relevant piece of clinical information, but operationally in a hospital setting, it's also very useful. There's 1,000 references I could provide. I'd like to acknowledge all of our institutions here, our research team. Dr. Lucarelli is my close collaborator on all these, and then my mentors here at Vanderbilt. And then a big thank you to our ECT nursing team for their creativity and compassion in allowing folks to access care. And then most importantly, a big thank you to our families who allowed us to use these videos. And I actually ended at 148. I did not think I would do that, but
I know,
I
I'm
did.
very impressed. But I'm also incredibly impressed with the 50 plus questions that are in the I think you take the win for most number of questions. So
Oh,
which is
good.
great. I know, it's awesome. It's totally awesome.
Mhm.
So thank you. And I always appreciate hearing you talking about catatonia because it is so intense and until you've kind
Yes,
of seen it in real life, it's hard to wrap your head around it. And so I love how you help us to understand the depth and the intensity that that many people with autism and catatonia experience. And so thank you for that.
of
A
course.
whole bunch of questions. So I
Yeah.
can summarize a handful of them into
Okay.
help us better understand the ECT process, meaning
Yeah.
how long does a session last? You did discuss how many, on average, the 31, if you
Yeah.
will. But talk us through that a little bit.
Sure. So we treat about 15 to 20 patients a day here at Vanderbilt. McLean treats about 50 patients a day. They have two teams going at the same time. You come into the ECT suite. It looks like a PACU, so it looks like a pre-surgical area.
Mm,
We have
okay.
6 beds. We have a full anesthesiology team and attending anesthesiologist. We have a full nursing team, and then the psychiatrists and the trainees and residents there. You come in, you get your IV placed. After your IV is placed, we put you under general anesthesia. The entire process takes about an hour. The average length of seizure is about 30 seconds to 2 minutes. And most of that time, patients are in recovery. So we're just watching them to make sure that they're doing okay before we send them home. So that's really the process. We have folks who drive from all over the southeast to get treatment with us, and are they're able to go home that day. So if folks are driving, we tell them not to drive the day of ECT.
Mhm.
But beyond that, there's not a whole lot of limitations.
Okay. Awesome. Very helpful. So a couple of folks that are asking a little bit about basically how do they know when they should be thinking about catatonia, even
Yeah.
including, for example, a speech therapist is asking, hey, I work with a lot of people on the spectrum. When should I
Mhm.
be thinking about this? Another similar question is, how do we know the difference between catatonia and profound autism plus self-injury? So
Totally.
some of those kind of nuanced questions that I think are
Yeah.
really relevant for us to consider.
Absolutely. And they're really difficult to answer even for me, for somebody who does this every day, all day. So when you're evaluating a patient who with profound autism, or really anyone, the biggest thing to note is how far off their baseline are they? Like, is there a moment in time where you can go back and say, we were speaking, or this patient was using an AC device, or they were signing, and then that stops? Or were they, able to use the bathroom appropriately, and now they're having lots of incontinence? Were they eating independently, and now you have to prompt them to eat? Were they having way less hyperactivity, and now they're having significant degrees of hyperactivity and not sleeping? And then the self-injury aspect of it is when I think of catatonic self-injury, it's never in an effort to communicate something to someone. So you're not saying, I want my tablet, or I want to go home, or like, I'm really angry, or I'm hurt, or I'm frustrated right now. It is much more automatic, and which actually makes it more dangerous. So there's no way to predict it. It happens out of the blue. And the intensity and severity of it, in my experience anyway, is much higher than you would expect self-injury for someone with profound autism at baseline. So those are the delineating factors that I consider. And the same is true for aggression, right? So
Mhm.
folks with profound autism, they have aggression, right? That, they're trying to communicate something with someone. When you're having aggression that's interfering with your ability to walk past strangers, that's much more concerning for catatonia than aggression towards a, caregiver, if they're removing a preferred object or something like that.
Mhm. Mhm. Totally makes sense. Thank you. That's helpful
Mhm.
distinction. A couple other people are asking some questions about what is malignant catatonia, and so what does
Yeah.
that mean, and that kind of
Yeah.
thing.
Yeah, I should have done a better job defining that. I apologize. Malignant catatonia is catatonia that's associated with autonomic instability, so with vital sign changes. So folks can alternate between having a really high heart rate and a really low heart rate, or really high blood pressure and a really low blood pressure. Or they can alternate between having a really high fever, like a really high temperature, or really low fever, hypothermia. So, and they can fluctuate between those things. And that happens in about 10 to 20% of untreated cases, not treated, untreated. And it's life-threatening if it's occurring in that context.
Yeah, absolutely. Another, I think, really important question to think about in the context, and I agree with you, like I've done nothing like you do related to catatonia, but in my own patient population, trying to keep my antennas up so that I'm not
Mm,
missing catatonia. But when we think about sudden onset,
mm,
is there any kind of general definition for what we should be considering as sudden on, meaning sudden changes in that behavior like you described?
mhm. Yeah, I think that if it's a significant departure for someone's baseline that's not improving,
Okay.
like if folks regress, right? Like everybody regresses under stress. Everybody has some degree of like behavioral change, right? But usually when that stress is removed, your time passes, regression improves, or you come back to where you were. Generally in catatonia, that's not happening, right? So, but that we have not published this data yet, but there also seems to be some connection between really stressful life events and catatonia,
Mm.
particularly in our profound autism group. Like I met a young lady who moved from California to Tennessee, and she became catatonic as soon as she got off the moving truck. Like it's there are really stressful life events that certainly can contribute to. So it's stress, it's medical illness, it's psychiatric disorders. It's all of those things. And so just being aware and looking for how far off our baseline are we, and are we improving? And if you're very far and you're not improving, then catatonia should be on your differential.
Yep, great. Makes sense. Some other important questions that are coming in. People are curious about kind of thinking about this in relationship to pans or pandas.
Yeah.
I'm actually pretty curious about that too. Just trying to think through, I get that they're not the same thing, but do you know if there's any data to suggest that there is any interrelationship between the onset of catatonia in relationship to pans or pandas?
No, and we need to do more research on that. And my statement right now is purely speculative, but I think of PANS and PANDAS the same way I think of Down syndrome regressive disorder. So
Mm,
Down syndrome regressive disorder is a well characterized phenomenon in folks with Down syndrome that can present with catatonia. And I think of the same way with PANS and PANDAS, where it's a well described phenomenon that can present with features of catatonia. So both of those. So folks with Down syndrome have elevated inflammatory markers at baseline. So that folks with Down syndrome, if you look at their immune responses, they look like they have COVID. Like a neurotypical person has COVID, they
mm.
have that same sort of immune response, but just walking around all the time. And so that increases their risk for catatonia from like a neuroinflammatory perspective. And I feel the same way about PANS and PANDAS. It's like you're having neuroinflammation, it's diffuse, it's happening in the brain, catatonia is associated with that. That's how I conceptualize it.
Okay, that's helpful. Thank you. A couple other questions that are related to, if a clinician is thinking about catatonia, maybe they do a benzodiazepine challenge, some Ativan challenge kind of thing. How long should they try the benzo before, without seeing an effect, before they bail and
Mm-hmm.
think it was that they made the wrong diagnosis? And I actually get that a lot too, where people will say,
Yeah,
"Oh, we did an Ativan challenge." And nothing happened, so it can't be catatonia. So help us
yeah,
understand that in a relationship.
yeah. I think that the Ativan challenge is a so for those that don't know, when you see a catatonic patient, the first thing you're supposed to do is give them Ativan to see if they improve. And the vast majority of catatonic patients will improve if you give them some Ativan, at least a little bit. What I'd say is if you give someone Ativan and they're not sedated, that's also a diagnostic sign, right? Like if they're still not sedated, then you should continue to repeat the dose. The other one is trust your instincts, right? Like there are people who have Ativan refractory catatonia, and I think some risk factors for that are how long has someone been catatonic? Like if they've been catatonic for a year, I would be shocked if they respond very quickly to Ativan. I think of catatonia similar to I think of epilepsy, so more seizures equals more medication refractoriness.
Mm,
So, the more ill someone is, the longer they're ill, the more likely it is that medicine's not going to be as effective. I also think autistic folks that are catatonic or catatonic are more likely to be refractory to Ativan. And I don't know really, I have theories as to why, but we only have 1 minute, so I won't go into that. And then, so if those are happening, but if you give Ativan, my point in saying all that is the lorazepam challenge is a tool, right?
mm.
It's a diagnostic test. So if you give it and you're still concerned about catatonia or there's still signs, like it's not a definitive the way that I think we used to conceptualize it.
Okay, that's really helpful. Thank you, because I've actually run
Mhm.
into that a handful of times myself. Not with
Yeah,
me doing the challenge, but with me being the recipient of someone having challenged a patient um, with Ativan and then saying, "Oh, it can't be that," and I'm like, "Ah."
right.
So thanks, that's super helpful. All right,
Mhm.
so last couple, or really the last question that I'll ask is kind of about access. So
Yeah,
a lot of folks are asking, okay, I think I might have a patient who is experiencing this. Now what? Where do I go? Where
yeah.
do I start? What do they do?
The Catatonia Foundation is a great place to go. It's the catatoniafoundation.org. They are doing, I think, a really good job of trying to connect people with resources.
Okay.
I would, reach out and see if there, a lot of our psychiatrists who are well equipped to diagnose and treat catatonia are ECT docs.
Mm,
So if there are local ECT docs who would be willing to do a consultation for you to evaluate the patient, I think that's also smart. Um, and then, just trying to collaborate with your psychiatry colleagues. And for better or for worse, catatonia has sort of lived in psychiatry for a really long time. And so I think if you're able to consult with some of your colleagues in psychiatry, that would be where I would start.
excellent. Okay, great. Very good. All right, thank you. Again,
Yeah.
really appreciate how well you cover that topic and help us to just, I know we only hit the tip of the iceberg of this very important and complex topic, but I really
Yeah.
think it, hopefully, especially given how many people have amazing questions about it, I think you really jiggled some thought-provoking ideas for people. So thank you.